I'll wait. I'll wait another few seconds for everyone to join, and then great. So we have a great topic today. Good morning. Welcome to Grand Rounds. Sorry, the topic changed, but then thanks to Dr. Huddleston, we are still able to meet and have this wonderful talk, which we would have had at a later date, perhaps. So over the last 35 years, the lung transplantation has become a viable treatment option for a variety of end-stage lung diseases. And for my history buffs, because I know you guys pretty well, the first transplantation with the human lung transplant was done in 1963, and that survival was 18 days. But eventually in 1983, the first lung transplant was done for idiopathic pulmonary fibrosis, and then in 1986 for COPD. And now we all know that survival rate is at least 80% in the first year due to surgeons like Dr. Huddleston and committed people who will take care of the patient post-transplant. We are very fortunate to have Steve Huddleston, who's a director of the lung transplantation program at UMMC. Dr. Huddleston is a cardiothoracic surgeon. He is clinically interested in lung transplantation for end-stage lung disease, valve repair, complex and redo cardiac thoracic surgery, and aortic dissection repair, coronary artery bypass, and surgical treatment of atrial fibrillation. Initially trained at Columbia University, he did his residency and postgrad from University of Minnesota. His fellowship was at University of Minnesota and Johns Hopkins. Extremely talented and covers a lot of hospitals in Metro, starting from UMMC, St. John's, VA, Hennepin, and a great teacher. I quickly, when he was putting his slides up, I quickly saw them and I thought this is going to be a great talk. So please hold back your questions and we will wait for them until the end. And here's Dr. Huddleston. Thank you so much for doing this talk.
And thank you for that kind and generous introduction, Dr. Kaur. I'll try to live up to the expectations. I'm going to be speaking about lung transplant in general, and then especially how we've been impacted during the COVID pandemic with our lung transplant program. I don't have any relevant disclosures, and this is suitable for a 1 AMA PRA Category 1 credit. I specifically wanted to mention, I will talk a little bit about a donor lung preservation device called the TransMedics Lung Organ Care System. And we've been involved in research with this device here at the university for almost a decade now. It's been tested at centers all around the world and several different trials. I don't have any financial interest in this platform. So I'm going to go over some lung transplant statistics, and those will be peppered throughout the talk. And some of them will be nationwide, some will be UMCC Fairview. And I'll also talk a little bit about the basic fundamentals of lung transplant, just because it is kind of a rare treatment modality and it may be obscure to some of the listeners. And then after I go through some of those basic fundamentals of lung transplant, I'll talk specifically about how lung transplant programs and our program in particular have been impacted by the COVID pandemic. One thing I will say just related to history that Dr. Kaur mentioned is the first lung transplant with decent survival was in 1983, and the first lung transplant at the University of Minnesota was in 1986. And this reminds me of kind of a funny story. Dr. Marshall Hertz was the first medical director of the lung transplant program. And the way Dr. Hertz got that job was the surgeon here at the time had kind of organized the transplant, and he had found a patient, and I think he was get in the process of figuring out how they would get a donor. This was before the UNOS directed allocation system with all the organ procurement organizations. So each center would just kind of go and figure it out where there might be a possible donor at their hospital or at other hospitals that they had a relationship with. Anyway, the surgeon had he was starting to, the wheels were starting to turn. He was starting to get this whole first transplant organized here at the University of Minnesota. And Dr. Hertz was a budding pulmonologist here. There was no lung transplant then, so he wasn't a lung transplant pulmonologist. But the surgeon asked him if Dr. Hertz would help him find a patient for a lung transplant. And Dr. Hertz said, sure. And he'd be happy to help with that. And he said, of course, he won't need a pulmonologist after the transplant because he'll have, a brand new set of lungs. And that's just absolutely absurd and hilarious to us now. It's actually even kind of surprising to me, considering they had no experience with it, that surgeon thought that. But the point of the story is that lung transplant programs, the backbone of any solid lung transplant program is the transplant pulmonologist. And I'm extremely grateful. And really, it's an honor and a pleasure to work with our group of transplant pulmonologists here at the University of Minnesota. They're a wonderful group of physicians, they're extremely knowledgeable, they're compassionate in the care of their patients, and they're just incredible doctors. And it's a wonderful practice working with them. This slide is from UNOS data from SRTR website, and you can get on there and you can look at all kinds of different statistics, but it just shows the number of patients on the lung transplant wait list during any given year. And it's typically runs between 4,000 and 5,000. It did increase a little bit the past several years, and then it dropped down during the COVID pandemic because it was difficult to evaluate patients for lung transplant during that time. This slide shows the overall number of lung transplants in the United States, which is between 2,500 and 3,000. And so the main point of this slide is to show, and this has also increased over the years, but the main point is to show you that there's quite a gap between the number of patients on the transplant list and the number of patients who actually get transplants, unfortunately. And this is because of limitations of donors, the number of donors and the donor quality. Now, this is really just the tip of the iceberg because there are about 200,000 patients a year in the United States who die of end-stage lung disease, most of them from COPD, but many from other causes such as interstitial lung disease, pulmonary fibrosis, complications of cystic fibrosis, and pulmonary hypertension. But only a few of those patients are fortunate enough to get through the lung transplant evaluation process and ultimately be listed, and even fewer actually get a lung transplant. Here at the University of Minnesota, our volume hovers between 30 and 50 lung transplants now. The past several years, more in the 30s and 40s. This year, we got off to a real hot start and did 12 lung transplants so far. Annualized, that would be 48. I don't think that it's going to continue. It slowed down a little bit in March. You never quite know what's going on. This is all completely driven by external forces impacting donors. We always have plenty of patients on the wait list here. The volume did increase back in the early 2000s, and I should mention Dr. Gabe Lohr was here during that time period, and he's a contemporary of mine who is very ambitious and came here with a lot of vision and with a mission to increase the volume in the lung transplant program. And he did that. And this is also when we started doing research with the ex vivo lung perfusion device, which I'll explain later. So the broad major categories of primary diagnoses that lead to patients to ultimately need a lung transplant are 4 different categories, 5 if you include other miscellaneous categories. And this is what UNOS uses in their listing when they calculate the lung allocation score, and also when they look at outcomes. And so you're all probably familiar with chronic obstructive pulmonary disease, patients with hyperexpanded lungs, and maybe not horrible oxygenation, but very poor ventilation and an obstructive defect. And then there are patients with complications of cystic fibrosis. The CT scan of this patient demonstrates a typical patient with cystic fibrosis who has a barrel-shaped chest and very dense lung parenchyma due to chronic inflammation and infection. The airways are extremely thickened here. You'll often find purulent mucus secretions pooling in the airways, and it just reaccumulates continuously during the transplant, such that when we take out one lung, the other lung can soil the field during the transplant because it's actively secreting pus, essentially. The other thing you'll notice about this CT scan, this is probably a relatively young patient, and their heart is pretty small. These patients don't typically have pulmonary hypertension. They don't have systemic hypertension, so they have a small heart. And these patients typically don't have terrific nutrition, unfortunately. And so they're quite thin, thin chest wall, and there's really no fat in the mediastinum either. And this is kind of a surgeon's perspective. I'm just pointing out some things that anytime I look at a CT scan, these things immediately jump out at me. And then this is a patient with interstitial lung disease, which will progress to pulmonary fibrosis. You can see the beginning of that happening here. These patients have enlarged hearts, often due to pulmonary hypertension and the right ventricular hypertrophy that occurs with that. And then they have lots of mediastinal fat. There's huge globs of fat in these patients sitting around. It's all very inflammatory, and it's stuck to the lungs around the hilum, and the lungs are drawn in and foreshortened. This is due to traction bronchiectasis that's pulling on the lung parenchyma, and there's all these lymph nodes up here as well in these patients. And so there's just a lot of inflammation. It makes these procedures much more difficult. So the percentage of patients on the lung transplant wait list by diagnosis category is another statistic you can look at on the SRTR website. And this is just to demonstrate that the majority of patients on the wait list, this is the percentage, the majority of the patients on the wait list have COPD, and this has increased over the years. Restrictive lung disease, interstitial lung disease, and pulmonary fibrosis. And this is increasing probably because the incidence and the recognition of interstitial lung disease and pulmonary fibrosis is increasing. And also, these patients have a worse prognosis than patients with COPD typically in general. And they get a higher score when you calculate their lung allocation score. So they're more likely to get a transplant. So there's kind of a push to get these patients with interstitial lung disease on the wait list and transplanted. COPD used to be the more common category, and that's gradually declined over the years. And I don't know if that's due to smoking cessation or better medical management of these patients, such that they don't have such severe disease and they don't need to undergo a transplant. Other categories, which are less well represented, but we do some transplants for, our patients with cystic fibrosis and patients with pulmonary hypertension. Now, some centers, if they don't have a center for cystic fibrosis, they wouldn't see a lot of these. And we do have an outstanding history of caring for patients with cystic fibrosis here at the University of Minnesota, really one of the leaders in the nation. And we also have a very strong pulmonary hypertension program here, especially with our heart failure cardiologists. And so we do see a decent number of these patients with pulmonary hypertension and cystic fibrosis, and these patients present their own unique challenges. So I always tell my patients that no one person is going to decide if they can have a lung transplant or not their primary pulmonologist or their referring physician, not the lung transplant pulmonologist who evaluates them here, and not the surgeon. In fact, it's not even just a doctor. Really, we have a multidisciplinary lung transplant committee, and it's not exactly like a black marble process where if one person, one care provider feels it's not appropriate, that they can throw in a black marble and rule it out. But we do need to reach a consensus on each patient before they're listed for lung transplant. And there can be some controversy sometimes. We have representation from nurses, social workers, nutritionists. Patients are evaluated by a psychologist. They also all undergo a palliative care consult now. And so there's a lot of different input and different perspectives on whether or not the patient would benefit from lung transplant. And this is very important because we're all focused on our own particular area, and we may have missed something that would be an important contraindication to lung transplant. But overall, the general idea is that we try to find patients who have end-stage life-threatening lung disease, and it needs to be irreversible, which is going to come up later when we talk about COVID-19, ARDS, and fibrosis. And they also typically would have impaired quality of life, and we would hope for an improvement in their quality of life. At our center, we look for patients with single organ involvement. We will occasionally transplant someone with chronic kidney disease. There's pretty much exceptions to every rule I'll mention, by the way. But we don't do multi-organ transplant at our center currently. I do have colleagues at other centers who are involved in multi-organ transplant, and we're not philosophically opposed to it here, but it is quite an undertaking and the outcomes are challenging. I'll leave it at that. So just talking so you can understand a little bit about when we're talking about end-stage life-threatening lung disease, one interesting diagnostic category to talk about is COPD, because as you know, these patients can live for many, many years. And so the question always comes up, when is the right time to listen for transplant? And the transplant pulmonologists use a Bode score, which looks at several different categories. The obstructive defect the patient has, which is their percentage FEV1, their 6-minute walk test, dyspnea scale, and BMI. And you can type in a Bode score calculator on Google, and you'll find the scale for it, and it'll tell you exactly what to look for in their dyspnea scale. And you give them a score between 0 and 3 for each of these categories, and a score of 0 if their BMI is less than 21, and 1 if it's, if it's greater than 21, and 1 if it's less than 1. So it's bad if you're malnourished. And then you add up that score between 7 and 10. And if a patient has a Bode score greater than 7, that predicts that they would have a survival benefit for lung transplant. Now, the data for this is actually pretty skimpy. If you go back and look at it, it's from some, I think, a Swedish study, and we're talking like 50 patients. And, it did seem that there was a survival benefit, but a lot of literature in the lung transplant, a lot of lung transplant literature, if you go and really dig deeper and look into it, it's not terribly compelling. These aren't huge population-based studies with powerful statistics, but that's kind of the number that we hang on. Now, some patients with a Bode score of 6, I do hear the pulmonologist talking about it, and they'll send them to me, and we'll certainly talk about it. But sometimes you catch patients when they look a little too good, and as we talk later more about the complications of lung transplant, you don't want to drag these patients down if you can avoid it. So as I said, we go through a multidisciplinary lung transplant evaluation. It's a systems-based approach. The medicine doctors kind of go through all the different systems and look for other medical problems that would impact the patient's perioperative course and also their postoperative course and how much they're going to benefit from lung transplant. If a patient has severe osteoporosis, for instance, and they can't walk and their bones are going to break, perioperatively and during the recovery, then they might not benefit from a lung transplant. Patients with inflammatory and autoimmune disorders that affect multiple other organ systems also might not benefit from a lung transplant. From a surgical perspective, we're basically looking at the patient and trying to figure out if we can get them through surgery. Are they frail? Are there technical obstacles that are too great to overcome? And we do this with the history, the physical, and then diagnostic tests, including the CT of the chest, echocardiogram to look at their right heart function in particular, look at valvular function, and a cardiac catheterization. In older patients, we do a left heart catheterization with the coronary angiogram, but oftentimes, more importantly, we do a right heart catheterization to look at their pulmonary hypertension and assess their right heart function that way. And then we also use a nuclear medicine ventilation perfusion scan, sometimes, especially when we're thinking about a single lung transplant, this is helpful. And then, as I mentioned, there are many other care providers who are involved on the team that look at other aspects of the potential lung transplant candidate. And these are often as important or more important than the surgical and medical factors. I cannot emphasize enough. you can have a lung transplant that goes very well technically and the patient benefits from it medically. But if they don't have the proper support system, or if they have issues with chemical dependency, if they have untreated depression, or anxiety, if they don't have the financial resources, many of our patients come from remote areas, and if they can't get back to the Twin Cities when they have a complication or if there's logistical problems, these are train wrecks that can't be undone at that point. And so we try to avoid that with the help of our other team members. So what are some of the contraindications to lung transplant? This is a moving target. If you open up a textbook and look at the contraindications to lung transplant, it seems pretty clear. Untreatable malignancy, end organ dysfunction, active infection, bleeding diathesis, significant coronary artery disease, BMI, non-adherence to therapy, substance abuse, poor social support. These are absolute contraindications, historically speaking, but these things are changing. We'll deal with bleeding if we can correct it. Patients with active infection, of course, that can be treated. End organ dysfunction, I mentioned we will occasionally do a lung transplant on someone with chronic kidney disease, and we will refer them to other centers if they have potential benefit from a multi-organ lung transplant, like a lung, liver, or lung kidney, or a heart lung transplant. Now, coronary artery disease has changed a lot. It's very common as the age has increased in the patients that we transplant. We see more and more potential transplant candidates with significant coronary artery disease. And we have a tailored approach to this. If it's stentable and the patient could potentially wait on the lung transplant wait list for some long period of time, like 6 months or a year safely, then we will ask the cardiologist to do percutaneous coronary intervention and put a stent in. If the coronary artery disease is not stentable and needs to be treated with surgery, or if the patient is probably not going to do well if lung transplant is delayed, then we'll consider a combined lung transplant coronary artery bypass grafting operation. And we've done 7 of these here at the university. It's not common nationally. People coming from other centers will often say they've never even heard of such a thing. But I know, talking to my colleagues at other institutions, one in particular who trained here, they are doing combined lung transplant cabbages as well. And it's become almost necessary due to the aging population that we're considering and the high prevalence of coronary artery disease in those patients. And it's also technically pretty feasible. Coronary artery bypass grafting is the most common operation that we do as cardiac surgeons, and it doesn't add a lot technically to the operation to do that. I will say that it makes the postoperative course more complicated, and we're still learning about this, and we're probably a little bit more careful than we were at first, but we've had decent outcomes with it. With a long and difficult recovery, we've had decent outcomes, and we'll probably continue to do this to some degree. Other absolute contraindications previously that we'll work around are substance abuse. Patients can go for ChemDep evaluation and treatment, and once they've addressed that, then they could be considered as a lung transplant candidate. Social support issues can often be mitigated. And when you look down at the relative contraindications, historically, we were really cautious about transplanting patients in age 60 to 65 age group. They'd often end up with a single lung transplant. And that's changed dramatically. We're now listing people up to age 70 and keeping them on the list up to age 75. We've done several patients in their 70s, and I will say their recovery is often a little bit more difficult. Just to kind of put it in a nutshell, we typically say that when patients are 70 and listed for a lung transplant, they need to look what we say, quote, perfect, which is kind of a bad way to say it. But from a medical standpoint, they really do need to look pretty perfect. Now, what is perfect? Could perfect be there was a little problem and it was corrected? Like, did they have single vessel coronary artery disease that was stented? And we are still learning about that and kind of arguing about that back and forth. I think time will tell. These patients are a little bit more challenging, and we're definitely pushing the envelope, but so are all other centers pretty much. Other relative contraindications that can be addressed are or mitigated include osteoporosis. Hepatitis C is now curable. Historically, once a patient was ventilated, many years or decades ago, once the patient ended up on the mechanical ventilator, they would no longer consider them for lung transplant. And of course, many of our patients now are on the mechanical ventilator or positive pressure support, or we transplant them intentionally off of ECMO, extracorporeal membrane oxygenation, which I'll talk about quite a bit more during the talk. And then there are technical relative contraindications, such as previous chest surgery, pleurodesis, or prior cardiothoracic surgery. And these are simply not contraindications to lung transplant anymore. Now, we will consider it in the overall evaluation. If a patient is, 70, frail, had a previous pleurodesis or cardiac surgery, and there's other factors like they don't have great resources or social support, then this certainly would weigh in as another factor. But if it's otherwise suitable lung transplant candidate, this would not be the only factor that would rule them out. So once you evaluate the patient, you're sitting in clinic, they always ask, how long will I be waiting on the wait list? And I really have no idea for any specific individual. It's very random. We'll put patients on the wait list with a high lung allocation score, and everyone has their fingers crossed hoping for a donor. And that patient can sit around in the hospital for weeks. And we do have patients who die on the lung transplant wait list, sadly. Then on the flip side of the coin, sometimes you'll put a patient on the lung transplant wait list who has a relatively low lung allocation score. It's between 0 and 100. 100 is the highest. 0 is like, you don't need a lung transplant at all. Most of our patients, when we list them and they're an outpatient, typically have a lung allocation score in the 30s. And I have seen patients get listed with a lung allocation score in the 30s, and they'll end up getting a donor offer within days. It's very, very random. But if you look at it statistically, and you look at it according to the primary diagnosis of the patient, the time hovers around, I would say, 2 to 5 months, depending on the diagnostic category. So for COPD, typically on the wait list around 5 months. For pulmonary vascular disease, it's now hovering around 5 months. It really dropped down a couple years ago when these patients got prioritized. For patients with cystic fibrosis, because they often they will be functionally in pretty good shape, and they'll, maybe have a decent 6-minute walk test or not be on that much oxygen. But so they didn't score that high, but they've corrected that in the lung allocation score to get them in line with the other recipients. Cystic fibrosis can be a pretty short wait time, and restrictive lung disease, quite a short wait time, because these patients are significantly prioritized in lung allocation score because they are the most likely to drop off a cliff clinically and get into trouble and not do well on the wait list for a long period of time. So once the patient's on the wait list, or when they go on the wait list, we calculate a lung allocation score, and you can type in lung allocation score in Google, and you type in all these different factors for the patient, and they'll come up with a lung allocation score. The lung allocation score, the idea is to get lungs to the sickest patients who are going to benefit the most from that. And as you can imagine, there's always some controversy around this. For instance, one factor is age. So being older gives you a higher lung allocation score and prioritizes you for lung transplant. The rest of this stuff makes sense for the most part, and it's based on statistical analysis, looking at lung transplant candidates on the wait list and how long they survive. And for many of these factors, the worse it is, the less time the candidate would survive on the wait list. Now, previously, in years gone by, organs were allocated according to the local organ procurement organization. So our organ procurement organization here in this region is LifeSource, and they cover Minnesota, North Dakota, South Dakota. The country's divided up geographically into this jigsaw puzzle of OPOs. And typically, the local OPO would allocate to the transplant centers within their OPO first. And then if there was no placement of the organs, then they would start to go outside of the OPO to surrounding OPOs or nationwide. And this has been abandoned in about November 2017. There was a lawsuit about this because in very population dense areas, like Philadelphia, New York, you'll have, instead of an OPO covering 3 states, like our OPO, you'll have an OPO that covers, I don't know, 3 square miles, or not even that, these very small little OPOs that have, enormous medical centers within them. They'll have, potentially lots of donors there. And there was a lawsuit around 2017, basically because I think a patient was, very near, it may have come out of New York, I can't remember exactly, but, or New Jersey. It was a patient, who basically, like, hospital down the street, the donor went to somebody farther away than a very sick recipient there. And I think that recipient may have died, I'm not sure. But or that candidate may have died. And the thought was that this was breaking something called the common rule, which is the rule that UNOS uses as kind of a guide as to how to organize allocation, and that's that the sickest patients should get the lungs, and especially the sickest patients who will benefit should get the organ. And so they came up with this 250 nautical mile rule. So if you draw a circle of 250 nautical miles around the recipient, the donor, the sickest recipient within that 250 nautical mile radius is at the top of the list. And this is probably going to be changed to a 500 nautical mile rule, and eventually we'll have continuous distribution across the country. And this is possible, because we have jets now flying around that are pretty fast, and also so you can go procure organs from long distance. And also we have these ex vivo lung perfusion systems now where we can preserve the lungs for up to 24 hours. So geography is becoming less and less of a factor. Now, at the University of Minnesota, we did notice a significant drop off in our number of offers when the 250 nautical mile rule was implemented. And unfortunately, there were winners and losers with this. Most centers were sort of winners or broke even. But if you're a center like ours, where you're geographically close to a high population area with lots of transplant centers like Chicago, and then on the other side of you is a vast wilderness with very few donors, then the way the math worked out is we had fewer donors, and we continue to struggle with this and try to work around it. But it's why we had that significant drop off of volume from about 50 plus lung transplants per year to the 30 to 40 range in around late 2017, 2018. Then just other factors related to allocation. Of course, it's done by blood group, so it's supposed to be kind of fair. If you're B blood group, you get the B lungs. And O's get the O's, and A's get the A's. And that way, if there's not as much crossover between blood groups, if you're in a smaller pool of, if you're in a blood group with a smaller donor pool, you're also in a blood group with a smaller recipient pool. So it should be fair. So looking at 3-year outcomes for patients. So what happens to the patient on the wait list? This is a really interesting slide. And one of my most interesting slides from SRTR data. Once you list people from time 0, if you follow them out 3 years, what happens? Well, 80% of them get transplanted with a deceased donor. We don't really do living donor in the US. So why didn't the other 20% get transplanted? Well, oftentimes they'll have antibodies, or there'll be some size issue, or they could just get passed up by their own center for some reason. But that's, I think, what explains most of this. There's something about that 20% that were listed, and maybe they should have never been listed. Or they just have such a long allocation score that they aren't high priority. Now, some patients just sit on the waiting list. Now, as you notice, it's less than 20%. So what happens to the others? Well, some of them died on the wait list, and then some of them were removed for some reason. And all that data is recorded on every person put on the wait list by UNOS. And that's to kind of keep track of that, so that so the wait list doesn't turn into a sort of purgatory for patients where they're put on and taken off without any oversight or follow up on the outcomes of that. Because just listing a patient or taking them off of the list has implications for their long-term outcome, as that slide demonstrates. So when we get a donor offer, there's several different criteria that we evaluate. Standard donors typically have a PF ratio, PO2 to FiO2 ratio greater than 300. We like them to have an ischemia time less than 6 hours, age less than 55, and little or no cigarette smoking history, and clear imaging, chest X-ray and CT, and a normal bronchoscopy. This almost never happens. We have, most of the time, bad things happen when a donor dies or has a significant neurologic injury, leading them to become what's called a donor cardiac death donor. I guess basically I should take a step back and just explain that there's two different types of donors. There's brain dead donors who have no brainstem function, and then there's donor cardiac death donors. And these are donors who have had a devastating neurologic injury. Their family was aware or thought that the patient would not want to go on like that, but they are supported on a mechanical ventilator. And after evaluation by a neurologist and if the prognosis is dismal, the family may decide that the patient would want to have the endotracheal tube removed. And if they thought that the patient also would want to have been a donor, then the organs could be procured at that time. Now, that's obviously a lot more complicated procurement, and sometimes the patient doesn't die. For our center, about 10 to 15% of the time, when we send a team out for a DCD donor, the donor doesn't die, and then we come back empty-handed. Other expanded criteria in donors include lungs that aren't oxygenating that great, oftentimes due to atelectasis. If the lungs are coming from a far distance, older age donors, we very often will have donors that have a greater than 15 pack of cigarette smoking history. There'll be concerning findings on bronchoscopy or imaging, and then we're now considering hepatitis C donors. So my main point about this slide is that everything's negotiable. It's all a grayscale, and we'll consider donors that have some of these different complicating factors if we think that the overall function of the lungs will be good. There's a separate category called public health service risk donors, what we casually call increased risk donors, which are donors who've engaged in behaviors such as IV drug abuse, prostitutes, people in prison more than 72 hours, men who have sex with men. They may be at risk, increased risk for having hepatitis C or HIV that would not necessarily be diagnosed on the donor evaluation. And patients always ask how would this possibly happen? Well, let's say a donor overdosed on intravenous heroin, and they didn't have hepatitis C, but there was some hepatitis C in that syringe that they overdosed on. What are the chances that a little bit of that hepatitis C is going to then infect them, but not be detectable, and then be transmitted to the donor organs? And this is all well established from statistics that have been recorded by the Public Health Service for many decades now. And the overall risk of transmitting hepatitis C or HIV to public health service to recipients from PHS risk donors is about 0.9% risk. And we have to get consent for this if we use these donors in recipients. So the overall deceased donor lung count is a little over 2,500 per year, hasn't quite reached 3,000. This correlates with the number of lung transplants in the US each year. How do we do a procurement? Well, typically they'll be procuring organs from the chest and the abdomen. And so the donor undergoes a midline sternotomy and a laparotomy incision. And there's multiple procurement teams there. Typically, there might be a heart team, a lung team, and an abdominal team. And the abdominal team may have a liver team that's separate. Everyone basically dissects around the vessels of the organs of interest. And then when everyone is ready to begin the procurement, the donor is given full dose heparin so that no blood clots form. The heart is arrested and the lungs are perfused with a solution called Perfidex that's designed to limit injury to the lungs and preserve them rapidly and decrease edema in the lungs. Ice saline slush is poured all over the organs, and then the organs are removed sequentially. The heart goes first, then the lungs, and then the liver, and then the kidneys and pancreas. This is just a device. So typically, conventionally, we preserve the lungs on ice. This is a newer device. This is called ex vivo lung perfusion. It's about the size of a dorm refrigerator on wheels. And it has this clear console that snaps in. This is disposable. The rest of this is not disposable. So this is snaps in here, and it connects to a ventilator and a perfusion pump that pumps blood through the lungs, and it ventilates the lungs. And this allows us to assess and observe the lungs outside of the donor. It also, we can keep them on this device for up to 24 hours. At our center, we've only done about, I think, 12 or 13 hours total. And potentially in the future, there may be some ways to modulate the lungs immunologically or to rehabilitate them. And different centers are working on research on this currently. It's FDA approved, and we were involved in several of the foundational trials for this device. This is just a video to give you an idea of what it looks like. So you can see the lungs here in the device. This is the console where we look at different data about the resistance of the lungs, the airway pressures, how well they're oxygenating, the temperature. It's graphed out here. So these are the peak inspiratory pressures and the pulmonary vascular pressures. You can see blood perfusing the lung through the pulmonary artery here, and the lungs are upside down. So the veins are facing, well, they're not upside down. They're the way they lay in the patient. This is the pulmonary vein here. So the heart would normally be sitting right in here, and this diaphragm surface would be down here. And this is the right lung, and this is the left lung. So you can see the blood that's perfusing coming out through the pulmonary veins. Now they're going to open up the console. So we can open up, this is all done sterilely, and you can palpate the lungs for nodules. And we can also perform bronchoscopy through the ventilator right here.
This is like when you go to a donor hospital.
So I think that gives you some idea of what that device is like. Pretty exciting technology. It is expensive. This is just some of the research that we've done here at the institution that's brought money into our institution to study and understand this device. There's a National Lung Donor Program now where there are procurement surgeons based at different centers around the country and different OPOs. And if a lung is basically goes through the normal allocation process and no one accepts it, it could become part of the National Lung Donor Program, where the lung is removed from the donor and then placed on the device. And at that point, it's allocated. The main use of this is for DCD donors. So as I mentioned, sometimes DCD donors don't expire. So if we're up here in Minnesota and we get called about a DCD donor in Arizona, and it doesn't sound like they're going to expire, then we won't send a team down there because that's, you know, it's some risk to put a team in the air, and it's $30,000. And if there's only a 20 or 30% chance that that donor is going to expire, we won't send a team down there. The problem with that is sometimes that donor does expire, and then everybody's slapping themselves and wishing we'd send a team down there. What the National Lung Donor Program allows us to do is a local surgeon there goes and sits at the DCD procurement. And if the donor expires, then they put the lungs on the device and then they allocate them. That's the main use of that. But there are also some other marginal lung donors or expanded criteria lung donors that might be placed on the device and then potentially be allocated. So surgical technique for lung transplant, there's different incisions that we use. First question is, are we going to do a bilateral or a single? There's different reasons to do a bilateral or a single. We typically try to do bilateral if we can, and we always do bilateral if the patient has pulmonary hypertension that's significant, because their right heart won't benefit if we just do a single. We also always do bilateral in patients with cystic fibrosis or any other really infectious lung etiology, where if we did a single in those patients, the lung that we left, the native lung that we left, would continually soil the other lung. So that really wouldn't be an option long-term. Then once we've decided if we're going to offer single or bilateral, and I should mention, some patients with interstitial lung disease and many patients with COPD would benefit from a single lung transplant. So it's a great option for them. Single lung transplants don't typically do quite as well as bilateral lung transplants long-term. Around 5 to 7 years, the bilateral lung transplant recipients start to do better than the single lung transplant recipients. Early on, older patients typically do better with a single lung transplant. As far as what incision we use, this is a clamshell incision, which is the standard conventional incision, transverse sternotomy, bilateral thoracotomies, and you get generous exposure with that. We've also done lots of cases here at the university through a sternotomy incision. It's kind of fallen out of favor because the exposure isn't as good. And we initially thought that there were fewer complications with sternotomy incisions, but we since found out that it seems that they're about the same as clamshell. Any incision you make could potentially have complications. If we're doing a single lung transplant, we'll typically go through a thoracotomy incision on one side. I have done some through a thoracotomy on one side, close that up, a bilateral. I've done some bilateral lung transplants through a thoracotomy on each side and not doing a clamshell incision. Clamshell incision is fairly morbid, and we kind of would like to avoid it if we could, but it's kind of hard to get away from the outstanding exposure it gives. We'll often use cardiopulmonary bypass or ECMO on transplant. ECMO is becoming more and more common. After we perform the transplant pneumonectomy, then we perform the implant. First, we do the bronchial anastomosis, then the pulmonary artery, then the pulmonary veins. This just shows the number of lung transplants per year in the US. As I mentioned, there's more bilaterals than singles, but singles are still around. Talk a little bit about postoperative course and recovery. I always tell patients lung transplant is the most difficult procedure that a person can undergo and potentially survive and endure. That may not be completely true. We do lots of other huge operations at the university, not just in cardiothoracic surgery, but this is a big one. And one of our fellows quipped a couple years ago that the complications of lung transplant are only limited by your imagination. If someone does well and they sort of stay on the pathway after lung transplant, they would be in the ICU for around a week, on the ventilator for 3 or 4 days, have a 5% chance of ending up with a tracheostomy. Sometimes this is done before the transplant. They'd have a hospital stay around a month. They'd have a 15 to 20% chance of readmission. They need to stay locally, and then they'd have frequent outpatient visits for the first year. However, that's just if they kind of stay on the pathway. If they start to have complications and it snowballs on them, then they can get into real trouble. And there's a 15% 1-year mortality with lung transplant. As I mentioned, I could have given a whole talk on the complications of lung transplant. It's really, really difficult, and there's multiple. And it's just, this is another time when it's really important to have that multidisciplinary team taking care of patients. We try as much as we can to minimize surgical complications like bleeding, and we have really cut down on that, because if you get started off on the wrong foot, it's really hard to recover from this operation. But even with that, even with no takebacks for bleeding for a couple of years now, we still continue to have problems occasionally with stroke. Infection and wound healing is always a problem that's dogging us. About 20% of patients end up with edema in the lungs or primary graft dysfunction, which is a multifactorial problem that leads to dependence on the mechanical ventilator and sometimes ECMO postoperatively. And then patients have potential complications of every other organ system. Once the patients do recover, the long-term outcomes of lung transplantation are not great. 5-year survival is around 60%, depending on the age of the patient, and it also depends on the primary diagnostic category of the patient. But it's for everybody. What I tell my patients is around 50% median survival at 7 years. So now what about COVID and lung transplant? Well, this obviously had a lot of impact on ours and many other programs, and it depended on where the wave hit you as to how it impacted you. A lot of the data comes from single center studies of lung transplant recipients with COVID-19 infection. And this is a bit of a data dump. I don't want your eyes to glaze over too much. The main takeaway from these series is that they're relatively small. They're single series. They showed evolving medical treatments as the treatment of COVID evolved during the pandemic. Transplant patients typically have a high mortality. One important point that was established early on is that remdesivir has a drug interaction with tacrolimus that results in reduced levels of tacrolimus. So this has to be corrected, or another agent has to be chosen for immunosuppression, or immunosuppression needs to be decreased. And these patients, lung transplant recipients who get COVID, may have a permanent decrement in their lung allograft function. This is a study from Spain. It was one of the earliest ones to report their experience in patients who had previously had lung transplant, who got infected with COVID. The patients were 4 years out, typically from transplant. Many of them had chest X-ray abnormalities. They treated them with the medical treatment that they had available at the time. This is probably from 2020, when these patients were getting COVID. They noticed the interaction between tacrolimus and remdesivir. They had a high mortality. 40% of their patients died. And this is where they noticed some risk factors associated with that, which were worse respiratory status on presentation and some of these blood clotting abnormalities and general inflammation leading to morbidity. This is another single center study where they compared patients with COVID-19 to patients from a recent period of time who got RSV infection. And the bottom line was COVID-19 was worse than RSV, but not horrible in this particular center. Their overall hospital survival was 88%, but they did notice this decrement in lung function. In our center, we had at the time of the COVID pandemic, we had a little over 300 patients who were alive after lung transplant. We've performed 1,000 lung transplants since 1986. Of the 341 who were alive at the time of the COVID pandemic from January 2020 on, 7.7% of those, a couple months ago, I got this data from our statistician and Jagadish Patel, our director of lung transplant, and 7.7% of those patients had developed a positive COVID test. Mortality was a little over 20%. These numbers are still changing and evolving as COVID changes and evolves, and our treatment and approach to this is in evolution. Some of these cases also may have been missed because some of our patients are remote from us and we don't have real regular follow-up with them. Talk a little bit about lung transplant for the treatment of COVID-19 ARDS fibrosis. The first case was reported out of China. There's a bunch of early case series, and we have our own 4 patients that we've done here. So the first case was done early on in the pandemic. It was a 58-year-old. He was placed on VV ECMO for 7 days. And this is pathology from the explanted lungs showing severe fibrosis. So as I told you during the early part of the talk, when we're talking about indications for lung transplant, we don't typically do lung transplant in the acute phase of a viral infection. But there was something about COVID early on that physicians caring for these patients, they felt it was very different than other viral infections of the lungs that led to this vicious ARDS and fibrosis that they predicted was not going to be reversible. And I would just say, taking a step back, that we actually don't know that for sure. That hasn't been proven. What is ECMO anyway? Just wanted to talk about this a little bit because everybody's talking about it these days. And I think it's important for everyone to have some fundamental basic understanding of what ECMO is. So this is how VV ECMO originated. This is a conventional setup for VV ECMO, where blood is drawn out of the femoral vein. It runs through a pump. It's controlled by this console. It's pumped through the oxygenator, and this oxygenator has a bajillion polymethylpentene hollow fibers that have oxygen and sweet gas flowing through them. And then the blood washes over the outside of these fibers. And that's where the gas exchange occurs, is across the surface of these fibers. They used to use membranes and they had all kinds of problems, plasma leaking across them and whatnot, and high resistance. This is a very low resistance system. It's sort of like a gill on a fish. You can think of it that way, as a giant polymethylpentene gill. And it works really well. These things are amazing. They can go for weeks without being changed out. Sometimes it's days. You can run the patient off anticoagulation with this. And then after the blood's oxygenated, you put it back into the jugular vein with the cannula inserted right down by the tricuspid valve. So oxygenated blood now goes through the lungs. Now, more recently, or actually not that recent, about, I'd say, 10 or 12 years ago, a cardiac surgeon invented this thing called an Avalon cannula. And this is a cannula within a cannula. So this cannula draws blood out through the outer cannula that comes up here into the oxygenator, and then oxygenated blood comes through the inner lumen, which has a side port opening by the tricuspid valve. This seems wonderful, but it can be kind of twitchy. And if this isn't in the right position, if it's above or below the valve or it's turned the wrong way, oxygenated blood doesn't go in here. It can end up short circuiting with the end of the cannula, where the oxygenated blood gets sucked right into the pump again. And so you just have a lot of unoxygenated blood going through the heart. So it doesn't always work great, but it usually does. And it's a wonderful tool that we use quite a lot. Tell you about a case presentation here at the University of Minnesota. We had a 40-year-old woman with COVID-19 pneumonia and ARDS. She presented in June 2021. She quickly progressed in her disease severity and was intubated, placed on ECMO, sedated, paralyzed. She had some complications, right, like a right basilar pneumothorax. A chest tube was placed. She was treated with the available medical therapy without any relief. Tracheostomy was done almost 2 months after her initial presentation, and she began to undergo rehabilitation while she was on VV ECMO And so now this is mid-August. So a month and a half after initial presentation, she underwent multidisciplinary lung transplant evaluation. Just take a step back and reiterate this point that I mentioned already. We typically offer lung transplant because this is the first discussion point that comes up with this patient. We typically offer lung transplant for patients with, chronic end stage fibrotic lung disease, that we know is not going to get better. Big question is this ARDS going to resolve? Is it going to get better? We felt relatively safe saying that a little over 6 weeks out, that we were in the chronic phase and this wasn't going to get better. Still not 100% sure, but even if it could potentially get better, if you could keep the patient on ECMO for, so let's say, a year, would they survive that ECMO? No one really knows the answer to these things. This is just another study looking at the histopathology of COVID ARDS. I'm not a pathologist. I can hardly look at the slide anymore, but the bottom line is here, there is a lot of fibrosis. This is not normal lung parenchyma. And there's these casts of fibrocytes and stuff in the airway here. So it looked bad. People thought that these lungs wouldn't recover. And so lung transplant became an option for some patients. And this particular patient of ours, for this case presentation, we did a clamshell incision. We put the patient on VV ECMO and then converted later in the operation to cardiopulmonary bypass, or the patient came in the operating room on VV ECMO and then converted to cardiopulmonary bypass. We had a lot of adhesions. The lungs were we did not have a lot of adhesions. Although in other COVID patients, we have had quite a lot of adhesions, and other series have reported this, but we notably did not have that in this case. The lungs were very fibrotic. It was not an easy case, but went fairly well. And this is just to show you a cardiopulmonary bypass circuit. It's in distinction from ECMO, it's an open circuit. This blood reservoir here is open. This is open, not to air in the room. I mean, it's sealed, but blood from the patient pools in this circuit. And this gives us more control during the operation. So if we have bleeding during the operation, it gets collected and sucked back into these pump suckers that empty into the blood reservoir. And that's the main distinction between cardiopulmonary bypass and between ECMO. Cardiopulmonary bypass, you have to have somebody sitting right there, babysitting it constantly, like second by second. ECMO, you can turn your head away for a minute anyway. So the patient did well postoperatively. She didn't have any major complications, mostly anxiety, I think, for being cooped up in the hospital for a couple months, but she's recovered and done well and got her tracheostomy out. This just shows you her chest x-ray before the transplant with the severe infiltrates and the fibrosis developing, her tracheostomy tube. This is the ECMO inflow cannula. You can't see her ECMO venous cannula that's drawing blood out down here because it's below and down, further down in her abdomen. This is her chest x-ray about a month or so after transplant. It shows relatively clear lung fields with sharply defined sulcus on this side. Diaphragm's up a little bit here, probably because we have a little bit of atelectasis in the left lower lobe. This is a very common problem in our patients. But overall, this chest x-ray looks beautiful, and she can certainly go on and live a long time and have good quality of life with that. It was very rewarding. She's a mother of, I believe, 5 kids, and very happy story there. Other centers have reported their small case series. Toronto had 3 cases they published on, and based on these series, different groups are trying to come up with guiding principles for transplantation and COVID patients. I'll wrap this up here quickly. Basically, we're trying to find a sweet spot when the patient is in the chronic phase, and irreversible, but not yet debilitated. This has been difficult to do. There's a study with 12 patients that didn't show long-term outcomes. Some that have shown long-term outcomes have had very poor survival at 6 months. A study from Austria had a survival of 74%, so that's not great. And then there is some concern because patients with COVID who've been placed on ECMO have had some outstanding results and good recovery. And so there's this question of whether or not we should be doing lung transplant at all, and whether we should just support these patients on ECMO and let them recover. And that's the real concern, is that some of these patients that have been transplanted, maybe they would have been fine with just longer term ECMO supportive care. So like I said, based on this, there's lots of position papers coming out proposing some guidelines, but nothing's been established yet. Our experience here, we've had 6 patients who had complications of COVID who were listed, 4 were transplanted, and 2 died of complications of ECMO while they were on the wait list. One of the stories of one of our patients who was transplanted was published in the Washington Post. If you want to look up this very nice story, this patient did pretty well. Another young patient, carefully selected. We've been pretty cautious and conservative in our approach. Unfortunately, the majority of referrals for patients with COVID ARDS have significant contraindications, and they're not candidates for transplant. I put in several examples of this, but these patients are typically prone, paralyzed, have no neurologic exam, have never heard of or discussed transplant before. They've not been able to communicate with anyone recently. They often have horrible infectious complications, and they often have open wounds, severe deconditioning, cannot stand, requires a Hoyer lift. These patients oftentimes were months into their illness and with not a lot of hope of recovery and not really having transplant as an option. And then the last thing that I wanted to just mention was use of or lung donors during the COVID pandemic. This is another angle that we've been affected by. So early on, we thought we would just avoid this. You know, we wouldn't use donors who had COVID previously. There was a patient who had a lung transplant, and they later found out that their donor had COVID, and that at another center, and that was published, and the patient actually did okay. And then at our center, we had just been avoiding it, but then after COVID, after Delta and Omicron, all the donors, or a lot of the donors, have had COVID previously, and so we've kind of come up with some guidelines for that, and I'll just talk about those briefly here. So if there's no acute infection on the nasopharyngeal swab or bronchoscopy specimen PCR, then we'll use them. If they had previous COVID-19 infection, if it was symptomatic or required supplemental oxygen, or there were radiographic abnormalities, we would not use the lungs. On the flip side of things, if they had COVID previously, but it was asymptomatic, they didn't require supplemental oxygen, there were no radiologic abnormalities, we will consider them. Now, the question is, how recent of COVID infection? We actually, the first one we used had COVID diagnosed 8 days earlier. It was diagnosed incidentally on the presentation of the donor, and it was diagnosed on a nasopharyngeal swab. On multiple subsequent nasopharyngeal swabs and on a bronchial specimen, it wasn't detected on PCR testing. And after obtaining consent from the patient and consultation with Transplant ID, we decided to use that donor. The recipient's done well and has had no evidence of COVID infection and has been tested for COVID. Incidentally, and I know this is a lot to take in, but that donor also had hepatitis C. It was a known hepatitis C donor. The recipient was hepatitis C negative and also consented to that hepatitis C donor. The recipient did have some detection of hepatitis C virus and has been treated for hepatitis C now. Kind of mind-blowing. This is a summary, just kind of going over what I've talked about. I don't have a lot to add. I'm open to questions if anyone has questions.
So you said mind-blowing, and I was inspired, and I was also intimidated by this talk, how much patients have go through, and we had so much inspiration and awe for you. This is amazing.
Thank you.
So I've received 5 or 6 questions. It's 8:02, so I will ask the couple of questions which are of similar nature, and I think they're relevant. Excuse me. Sorry. So how important is the match for lung transplant recipients, the ABO and tissue match?
So ABO is critical. We don't do ABO incompatible lung transplants. That would be a medical error if it were to occur. We have multiple mechanisms in place to prevent that from occurring. It has been done, but not widely and not on purpose. And there's ways to treat it if it were to occur, but the prognosis would not be good. RH compatibility doesn't matter for lung transplant. I don't know enough about the immunology of that to tell you exactly why, or the hematology of that, but RH doesn't matter. It's just the ABO. And then what was the other question?
So the other question is about the xenotransplant.
Oh, yeah.
So
Okay, and then one other thing I will say about matching is, so for kidneys, they match the human leukocyte antigen or major histocompatibility complex antigens. So, you know, our immune cells, everybody's immune system is a little different. And there are these major antigens that are involved in antigen presentation, which are distinct between different individuals. You get one haplotype from each of your parents. There are different serotypes of MHC and HLA molecules out there in the community, some more common than others, but there's a lot of diversity. And that's the major obstacle in lung transplant. Now in kidneys, like in bone marrow, they do perfect matching for HLA. You know, they have these large databases and they can wait, and they have banked marrow. They can do perfect matching for HLA. And so then they have better outcomes because of that. They do have minor antigens they have to deal with. For kidney, they do some HLA matching. For lungs, it's just not possible. There's not enough lungs. The patients are too sick. They don't have that long to wait on the wait list. And the lungs are spread out all over the country. So we don't do HLA matching. And that's probably the reason that we have so much rejection. As far as xenotransplantation, I don't know. I do some transplant immunology research, and I work in relatively when I was doing animal model stuff as a surgery resident, it was a relatively simple model with one antigen, you know, that could be tracked, and all the cells specific for that antigen could be tracked and identified, and you still saw pretty severe rejection. Xenotransplantation is a very high hurdle to overcome. And I used to say cynically that xenotransplantation, well, there's a famous quote by Norm Shumway that xenotransplantation is the future of transplantation, and it always will be. I think I recently had come to think that we were maybe getting closer to xenotransplantation being a reality. And I think in large animal models, there has been significant progress. But I think in humans, we're still a long way from making xenotransplantation a reality. There's just a lot of rejection. You know, it's really difficult to overcome all those antigens. There's a lot that we aren't even addressing yet. And I will say also in the large animal models, they're on really significant immunosuppression. I'm not sure that a human can live a normal life on that. So I think we're a ways off, but I'm not an expert on it. I don't do research on that field. Maybe there's some, you know, some key, some silver bullet. And as soon as that's, you know, addressed or figured out, then, you know, I kind of got excited about it and drank the Kool-Aid recently. And I began to think, because there was that heart transplant in New York, and there had been some kidney transplants into, I know this is kind of maybe troubling, but there were some brain dead recipients who had been volunteered for an experiment where they put in a xeno kidney in New York. And then there was a heart transplant recently in Baltimore of a xenotransplant with a xenotransplant donor. But those haven't done well long-term. The heart recipient died, I think, after a couple of weeks, and no one's established why yet. I bet it was rejection related. I think it's a ways off, unfortunately.
Thank you. There are a lot of questions about the complications, but I think you kind of alluded to them in a slide which listed the complications. I mean, this talk was layers and layers of multiple talks. So yeah. I think for this audience, it's an initial introduction, and we thank you and Brendan Cassidy for arranging this talk.
Yeah, no problem at all. Happy to talk, and sorry I ran over time a little bit.
Oh, this is great. I think all of us were probably spellbound, and I definitely personally was intimidated. And I was thinking that among all the organ transplants, probably lung must be the most scary one compared to kidney, or, you know, the donor finding, or even the heart probably. So
I think liver is pretty scary too, but I hope they don't take it personally. No, it's a big undertaking, but we have a great team.
Thank you so much. Thank you for this excellent talk. Have a great day.
Thank you.
Everyone.
Take care. Thank you.
Everyone, I'll see you next week. So thanks.